Hello, my name is Christinna Thorpe, and I will be presenting my scholarly project, the implementation of a nurse-driven telemetry discontinuation protocol. This project was completed with the help of Dr. Jennifer Hoppner, my project chair, Dr. Rita Wunderlich as the second reader, and Nicole Dockery, the facility CNO and a community member. The purpose of this project was to investigate the impact of a nurse-driven discontinuation protocol on the use of telemetry at the project site. The aim of this project was to reduce the amount of time patients were monitored by telemetry and also reduce telemetry overutilization. Telemetry, or continuous cardiac monitoring, is a valuable and useful tool in the acute care setting that provides real-time readings of patients' hearts, rates, and rhythms. The overuse of this resource consists of telemetry being placed on patients who do not require monitoring, or when patients are monitored for longer durations than necessary. Telemetry overutilization has a number of negative impacts on patients, nurses, providers, and facilities. For the patient, there is an increased risk of undergoing unnecessary testing and procedures due to false alarms, disruptions in their daily activities such as therapy and sleep, and increased costs during their hospitalization. Nurses experience alarm fatigue from false alarms, possibly making them slower to respond to priority alarms. They also become distracted from pertinent patient tasks. Telemetry overuse also increases nurse workloads. Providers are also interrupted and distracted with calls due to false alarms and also have to review a large number of patients' charts quickly to discontinue telemetry on patients already being monitored due to depletion of the resource. This can lead to possible medical errors. Facilities are also affected due to the cost associated with telemetry. Through protocols such as a nurse-driven telemetry discontinuation protocol, a decrease can be seen in these impacts, including reduced transfer times, increased availability of a reliable resource, increased comfort and mobility for patients, less risk of delirium in the elderly, reduced distractions and alarm fatigue for nurses, and reduced costs to patients and facilities. An integrated literature review was conducted for the purposes of this project. The databases used for this literature search included Medline, Academic Search Complete, Supplemental Index, Cumulative Index of Nursing and Allied Health Literature Ultimate, Medline Complete, and Ovid Nursing Collections. The parameter and restrictions included publications between 2012 and 2022, full text, peer-reviewed, and the English language. 3 themes were identified in this literature review: telemetry overutilization, interventions, and quality improvement in patient outcomes. Telemetry overutilization. While continuous cardiac monitoring is a useful tool in the acute care setting, it is commonly overused. In 2017, the American Heart Association, or AHA, published updated guidelines that classified patients into 3 categories according to the benefit that monitoring would have, and they also included suggested timeframes for these patients to be monitored. Factors that attribute to its overuse are inappropriate ordering and monitoring patients for longer durations than necessary. Several interventions have been researched to improve telemetry practices. Some researchers have educated providers and nursing staff on the benefits of appropriate monitoring. Others have tested nurse-driven or physician-driven discontinuation protocols, as well as created policies to standardize telemetry ordering and discontinuation practices, and provided guides with instructions on how to reduce telemetry overutilization. Finally, researchers have also altered their electronic health systems to alert providers when telemetry is not indicated for patients who are being ordered telemetry, and added prompts for nurses or providers when patients were monitored for longer than the recommended time. On top of improving telemetry practices, patients had increased satisfaction, mobility, and comfort. Also, the costs associated with telemetry decreased, and an increase in adverse events was not seen in multiple studies. Using the research found in the literature review and following the guidelines provided by the American Heart Association, the following protocol was formed. After 48 hours of telemetry monitoring, nurses could review the patient's chart to determine if telemetry could be discontinued. The facility's electronic health record already contained a template for nurses to complete to assist them in making this decision. Also, prompts were already activated to notify nurses of when patients were eligible for telemetry discontinuation. If there were any concerns from nursing staff or providers concerning the patient's telemetry or its discontinuation, those parties communicated with each other and collaborated to make the best decision for the patient. The theoretical framework used for this project was Carter's change model. Dr. John Carter provided an 8-step model on how to establish an organizational change. The steps included establishing a sense of urgency, forming a guiding coalition, creating a vision, communicating that vision, empowering employees, communicating short-term wins, making the momentum last, and creating a culture. The way it fit into this project was that it explained how to get an organization to change its practices to become better, even if it seemed like something was set in stone. By creating that sense of urgency that some aspect of the facility needed to be changed, and then involving others at all levels of the hierarchy to make that change happen, it was more widely accepted than a member of supervision or management saying to do something. By getting input from all the staff, it was communicated how to make that change less burdensome and go smoothly for everyone. In creating a culture and having lasting momentum, the change implemented became part of the organization rather than something that participants were unwilling to do and would eventually stop doing because they did not feel it necessary. This project had a quantitative exploratory design and used a retrospective chart review to collect data on the times patients were monitored by telemetry before and after protocol implementation. Participants were not engaged or recruited. Patient information was de-identified for use in this project, protecting their confidentiality. Educational meetings were conducted prior to and after protocol implementation to educate staff and providers on the protocol and AHA guidelines, as well as address any concerns about the protocol. This project took place on 2 medical surgical telemetry capable floors at an acute care facility located in the southeast region of the United States. The sample for this project consisted of participants over the age of 18 with diverse backgrounds, with no gender exclusions. A total of 101 electronic health records underwent an inclusion and exclusion process and were included in the sample. 46 participants were part of the pre-protocol group, while 55 were part of the post-protocol group. Several tests were performed for the data analysis of this project. The Kolmogorov-Smirnov normality test and the Shapiro-Wilk test determined that an independent sample t-test could not be used, and the Mann-Whitney U-test would be needed to analyze the data due to normality. The Mann-Whitney U-test was used to compare the average time patients were monitored by telemetry in a pre-test, post-test design with an effect size of 1.41 and a confidence level of 95%. The p-value was less than 0.001, showing a significant reduction in the time patients were monitored by telemetry post-protocol as compared to pre-protocol. A power test was run to determine if the sample size was large enough to reflect a difference if one existed. The power was 1.000, showing that the sample size of 101 participants was large enough to show a difference in this project. Prior to the nurse-driven telemetry discontinuation protocol, there were no protocols or policies in place at the project site to guide telemetry practices. After the implementation of the protocol, patients' telemetry monitors were discontinued in a timelier fashion, also making the facility more compliant with AHA guidelines. The following histogram shows the hours patients were monitored by telemetry before the protocol was implemented. The average time patients spent on telemetry at this time was 105.78 hours. This graph displays the time patients were monitored by telemetry after protocol implementation. The average amount of time patients spent on telemetry after the protocol was implemented was 66.74 hours, meaning there was nearly a 1.6 decrease in the mean amount of time patients were monitored by telemetry in this project. This graph is a side-by-side comparison showing a significant decrease in the time patients were monitored after the protocol was implemented as compared to before the protocol was implemented. The limitations of this project include a lack of generalizability due to being conducted in a smaller acute care facility. In larger facilities, it may be harder to be as vigilant about ensuring nursing staff is using the protocol properly and train all of the staff before the protocol is implemented. This was mitigated by reaching the target sample size and the sample consisting of a diversified population. Also, a limited amount of time was allotted for data collection. More time would have allowed this author to determine if this change was sustainable. The protocol and its benefits were reinforced after the data collection period to address the limitation of sustainability. A barrier to this project included reluctant nursing staff who were uncomfortable discontinuing telemetry without a provider's order. This barrier was overcome by further education of these nurses, and also when they saw no adverse events occurred after other nurses used the protocol properly. Facilitators for this project were the immense support from various teams and specialists within the facility, and the valuable input they contributed to making this project successful. The expected outcomes for this project were achieved, demonstrating that a nurse-driven telemetry discontinuation protocol reduced the amount of time patients were monitored by telemetry and reduced the overall unnecessary use of telemetry. Overall, telemetry practices were improved at the project facility. This aligns with findings in previous studies, strengthening current research and supporting needed practice changes. Through the implementation of a nurse-driven telemetry discontinuation protocol, it was revealed that there was a significant reduction in the amount of time patients were monitored by telemetry through data interpretation. The literature supports the use of nursing discontinuing telemetry in a timely fashion using the guidelines published by the AHA to mitigate the negative impacts caused by overutilization. The limitations of this project should be addressed in future research. Generalizability can be improved by implementing this protocol in other larger facilities, and sustainability can be assessed if more time for data collection is allowed. This project justified the use of a telemetry discontinuation protocol to reduce the amount of time patients are monitored by telemetry, thus reducing unnecessary telemetry use. At the completion of this project, it was recommended that the protocol become a permanent change for the medical surgical telemetry capable floors at the project site. Moving forward, current and new providers and staff should continue to be educated on appropriate telemetry practices and protocol use. These suggestions will improve sustainability, while also continuing to improve telemetry practices and provide safe, cost-effective care to patients. Implications for future research are to establish sustainable practice changes through research by educating providers and staff so they can confidently and competently complete tasks within their capacity. More research is needed to promote appropriate telemetry use through both improving discontinuation and ordering practices. The findings and the positive feedback received from this project can encourage improving quality and cost-effective care in telemetry practices. In addition to reducing the time patients were monitored by telemetry, this project did not have an increase in adverse events because of discontinuing telemetry through protocol use. This finding is similar to previous studies. Also, by properly using telemetry, the negative impacts previously mentioned in this presentation are reduced. More research is needed to continue improving telemetry practices without compromising the quality of care patients receive and their safety. When telemetry is used appropriately, it benefits nurses, providers, patients, and facilities through cost reduction, fewer distractions, improved transfer time, and resource availability, among other things. Policymakers within organizations need to evaluate their need for practice change and analyze telemetry use within their facilities to make useful policy alterations. The project was successful in demonstrating a significant reduction in telemetry monitoring through the implementation of a nurse-driven discontinuation protocol. This protocol has become a permanent protocol on the telemetry-capable medical surgical floors within the project site. In the immediate future, promoting the protocol sustainability through continued education is taking place. Further research is needed to improve generalizability. Possible avenues for this include implementing this protocol at other facilities within the organization. Some are larger and have bigger patient populations than the project facility. Also, other interventions can be tested to determine if they improve telemetry practices, such as altering ordering practices so that patients who do not require telemetry are not placed on it at admission. While my role in the current facility will soon change as I obtain my nurse practitioner degree, I will continue to promote improvements in telemetry practices within the organization. This project provided me the opportunity to make meaningful changes for nurses, providers, and patients, and encouraged me to continue promoting quality improvement initiatives. The Maryville DNP program has been challenging, rewarding, and eye-opening for me. It has revealed my capabilities to improve practices within my place of work to help not only other staff members, but also to improve patient safety and quality care. It also revealed my ability to competently and effectively communicate ideas and improvements to providers, administration, and other staff members to make necessary improvements. Despite all the hurdles, trials, and challenges, this is an experience that I am grateful for and will never regret. If there are any questions concerning this project, please do not hesitate to contact me at cthorpe1@live.maryville.edu. These are the references used for this presentation as well as in the project. Thank you for listening.